What's up, future respiratory therapist? So I'm coming at you now with a video that was brought to me by request by another one of your fellow respiratory therapy students, and that person asked me to do a video over ventilator troubleshooting. Now, ventilator troubleshooting, again, I feel like I say this every video, but literally, again, could go on for days and days and days because the countless amount of ventilator troubleshooting that you're going to come across can vary. And what I've decided to do is to break this down into what I consider the 4 most common ventilator troubleshooting areas. Okay, so you're going to go to clinic tomorrow or the next day, and you're going to have a patient whose troubleshooting doesn't fall in this category. And I apologize for that. Look, here's what you need to know. In respiratory school, you learn the theories of respiratory therapy. And then when you go in the clinic, you put a human on the other side of that theory, and it never pans out the way you learned the theory. That's not right or wrong. It's just the fact of the matter. You can't do anything about it. It just is what it is, okay? So understand you're going to come across some scenarios and some situations that don't fit this particular mode, okay? And that's okay. Troubleshoot what presents to you, okay? What I'm going to do today is break it down into what I consider the 4 most common troubleshooting areas that often occur with ventilator management, okay? So the first one on the board I have here is PIP. And so oftentimes you're going to have a patient, and this is often a patient that's going to be in assist control or SIMV, some sort of volume control ventilation. And the patient is going to present with an increase in their peak inspiratory pressure. Maybe your alarm will go off. Now, I need you to understand this before I get into any specifics. Everything I'm saying today, especially with point 1 and point 2, is based off the idea that you have your alarm set at a reasonable level. Okay? You have to have them set accordingly. So if we're talking about a peak inspiratory pressure, whatever your average pressure is, you should have your peak inspiratory pressure alarm set somewhere in the ballpark of 10 to 15 centimeters of water pressure above that peak inspiratory pressure. And when that alarm goes off, you have to troubleshoot it. So let's just talk about it. Increase in peak inspiratory pressure. What would cause this to go off? Well, it's very simple, okay? It's actually very, very simple. And the answer here is any type of obstruction. Now, obstruction can be very vague, and it is very vague. But you need to understand that any type of obstruction is going to increase your peak inspiratory pressures. What do you mean by obstruction, Joe? The answer is this. Bronchospasm, that can cause an increase in your peak inspiratory pressure. Secretions can cause an increase in your peak inspiratory pressure. In any type of foreign body aspiration will cause an increase in your peak inspiratory pressure. A mucus plug will cause an increase in your peak inspiratory pressure. A pneumothorax will cause an increase in your peak inspiratory pressure. Anything acute lung disease that causes a decrease in your static compliance or your dynamic compliance can lead to an increase in your peak inspiratory pressure. And what you need to do is to ask, what is the obstruction? What is causing this peak inspiratory pressure? So for example, if the patient presents with sudden onset of wheezing, then it's bronchospasm and you need to administer a bronchodilator. Let's say your patient presents with bilateral or coarse crackles, then it's secretions and you need to suction your patient. Okay? If your patient presents with a known foreign body aspiration, then you need to remove the foreign body. Okay? If if it's a pneumothorax, let's say you do a procedure and you do a subclavian line placement, that will lead to potentially an increase in your PIPs, because the potential problem with an SVC is a pneumothorax. Okay, that will cause an increase in your PIPs, and you need to be able to recognize that, get a chest X-ray, verify, put a chest tube in, right? So the other thing that might cause a peak inspiratory pressure, it still falls under obstruction, is a patient biting on the endotracheal tube. Okay, so if you have a patient that is awake and alert and biting on the endotracheal tube, that will cause your peak inspiratory pressures to go up. Okay, they're not happy, they're agitated, they want this tube out, and this will present itself to you as a rise in your peak inspiratory pressure as they bite on and obstruct the endotracheal tube. Now, while we're talking biting on the endotracheal tube, I want to throw this out there real quick. Nothing to do with the TMC, everything to do with real life respiratory therapy, okay? Do not automatically resort to putting a bite block in, okay? That is one of my biggest pet peeves, is patients who have bite blocks in that don't necessarily need them. They lead to excessive secretions, they lead to excessive biofilm, and they lead to lip and skin breakdown. So only use bite blocks on the patients who absolutely necessarily need them, okay? For a patient who is biting on the tube, chances are your situation is this. Either one, they're ready to be extubated and get them extubated, or two, they need continued mechanical ventilation, and we should probably give more sedation. Okay? So that's my spiel on bite blocks. That's my take on increase in your peak inspiratory pressure. Anything that will obstruct or create the lung compliance to go down will cause an increase in your PIPs, and you got to ask yourself, what's the problem? Okay? Now, like I said, this could go on for days and days. I could go into graphics analysis at this point, and we could really look at the breakdowns of what's really causing the PIP in conjunction with our patient assessment. For right now, PIP, you should be thinking some sort of obstruction, and what do I need to do to fix that? Okay? Now, point number 2 here is, what if I get a situation where I'm having decreased volume return, whether it be tidal volume or minute volume? Okay? Now, again, we're talking volume control. You have to understand that. Volume control, we're talking decrease in volumes with volume control. Okay? Now, typically, when you have a patient that presents with a decreasing in volumes or a sudden onset of drop of volumes, then you're thinking a leak. Now, your job as the respiratory therapist is to find the leak. Now, where do I start, Joe? How do I find the leak? The answer is this. You start at the patient. A common area for a leak to occur is at the cuff of the endotracheal tube or the tracheostomy tube. If you do not have a cuff leak, then work your way back through the ventilator circuit until you find the leak. It is most oftentimes going to be somewhere between the patient and the ventilator. It has to be, okay? So maybe the patient became completely disconnected. You would get a decrease in volumes. You'd also get a decrease in pressures, okay? That one's pretty obvious. But just a volume leak will usually result, and you'll find the answer somewhere between the patient's cuff and somewhere else in a circuit. Maybe one of either the MDI adapter or the SVN adapter, or one of the water traps, or whatever it may be, may have become open or left open accidentally, it will present as a decrease in volume. Anytime you have a decrease in volume and a decrease in pressures, you need to be thinking leak. Think about your tires in your car. If you have a hole in your tire, what's going to happen to the pressure in your tire? It's going to go down, right? You have to fix the problem. So fix the leak and you'll fix the problem. Okay? So that's increased pips and decreased volumes. Increased pips, you're thinking some sort of airway obstruction. Decreased volumes, you're typically thinking some type of leak. The next one brings me to air trapping. Now, air trapping is a common problem that you need to be able to recognize. And here's how you recognize air trapping. You have to go to your graphics analysis, okay? So here we go. This is your flow waveform, okay? So you have your flow waveform here. You're looking at it. It probably looks something like this. And then on the expiratory side of things, it doesn't return to baseline. That's how you know you have air trapping. Now the question is, how do you fix air trapping? And the answer to that question is you have to reduce or decrease inspiratory time. In a volume mode of ventilation, the only way to do this without altering minute ventilation is by decreasing I time. To decrease I time, what do you have to do? You have to increase flow. That's typically going to be your answer. Your TMC is going to ask you a question like this. They're going to say patient is air trapping, or maybe they'll say patient presents with this flow pattern, and you have to identify the flow that the air trapping is present. They're probably going to give you some vent settings, and the vent settings are going to include a flow of 30, which we know is too slow. So what do you want to do? The answer is increase flow. Increasing flow will decrease I time. That will extend expiratory time and hopefully reduce the air trapping that's present. Okay. Now, the last point I want to talk about is your PV asynchrony. Now, when I say PV, I'm saying patient ventilator asynchrony. And the result, and what this leads to is basically saying that you have a patient and you have a ventilator and they're not in sync with one another. And the biggest problem with this is that too many times clinicians, physicians, whoever it may be, try to make the patient breathe like the ventilator. And that is a terrible starting point. What you want to do as a respiratory therapist is identify how to make the patient breathe like the human. I'm going to say it again. Too many times we try to make the human breathe like the machine. But in reality, as respiratory therapists, we need to make the machine, the ventilator, breathe like the human. Okay? This is going to show up in 1 to 2 of the most common ways. Various things can lead to this, but I'm going to give you the 2 of the most common. Okay? It can be 1, that they are flow hungry, or 2, they are volume hungry. Okay? Those are the 2 most common. Now, the way this shows up is while you're taking care of the patient. And you have a patient that is on assist control, ACVC, volume control, assist control, or volume control, SIMV. It can happen in either of those modes. Okay? You have a breath that's given, and then immediately after that, you see another breath given. Okay? And the question is why is this patient breath stacking? Okay? This patient is obviously not comfortable. We're trying to do low volume ventilation, but in reality, we're actually doing high volume ventilation. We're actually giving, let's say they're on a tidal volume of 400. By the time they breath stack, 2 consecutive breaths, they're actually receiving 800 mLs. So a concept that's supposed to be around preserving and preventing barotrauma is actually leading to just that, because you're stacking these small tidal volumes on top of one another. Okay? You're going to see this a lot. Your question that you have to identify is, are they flow hungry or are they volume hungry? Okay? One of two things. Typically, you'll have them on a flow of somewhere between 40 and 60. If you want to know the answer to what the problem is, flip them the pressure support. Give them a pressure support of 10 and watch them take several breaths. Let them settle in to how they want to breathe. Look at your flow graphics and identify what their peak inspiratory flow is. If you have them in AC set on a peak flow of 50, but in pressure support, their peak flows are 70, that's probably the problem. Okay? This patient has a drive that's asking for 70 liters per minute, but you're only giving them 50. So the breath is too slow for what their central nervous system is wanting. They can't help it. You can't talk to these patients. You can't say, hey, I know you really want this breath a lot quicker, but I just need you to relax and settle down. They don't respond to that. They want to breathe how they want to breathe as a response to their central nervous system, and you got to match it. You got to figure out how to meet it, okay? So put them in pressure support and see how they're breathing. If they're inspiratory flow and pressure support, and you'll know just by this, just like I showed you a minute ago, look at their flow. Measure that right there. If that says 70, then put them back in assist control and put the flow up to 70, maybe 75, maybe exceed their inspiratory flow, okay? And that will help them not be flow hungry, and that will improve patient ventilator asynchrony. Now, if you're meeting their flow and they're still asking for more, then they're probably volume hungry, okay? Which means the tidal volume you have set, although it meets research numbers and protocol numbers, it's not meeting their numbers, okay? This patient wasn't a part of that study, okay? And so the 6 mLs per kilo, it's not enough for this patient. So watch them. You have them set on 400 cc's of tidal volume. Put them in pressure support. If you're meeting their inspiratory flow, see what their tidal volumes are. What are they asking for? What do they want in a tidal volume? And oftentimes you'll find that you have them set on 400 and they're asking for 460. That's what they want to do. That's what they would do if you let them breathe exactly how they want to. They would be taking tidal volumes of 460. Okay? You got to talk to your team, your physician, and you got to say, hey, this isn't working. Our patient is asking, and they want tidal volumes in the 460 range, but we only have them on 400, and the result of that is that they're ending up getting 800. They don't want 800, they just want 460. But we're cutting them short at 400. Okay? So you got to talk, and you got to make this understandable. You got to present this in a manner that gets through to your physicians to say, hey, if I increase the tidal volume to 475, guess what? They're not going to ask for more volume because we're going to be meeting their demand. We're going to be meeting and we're going to be satisfying the patient, making them more comfortable. Right now, they're not comfortable. They're angry. They're hungry for more volume. And so let's give it to them. Okay? So that's the first thing. That's the second thing when it comes to volume hunger. Now, the last thing and the last resort is to give more sedation. Now, there's several studies out there and a lot of research out there that says increased sedation leads to increased ICU psychosis, and all of that should be avoided. And if we can make the ventilator do what the patient wants instead of trying to make the patient do what the ventilator wants, your job as a respiratory therapist will become much easier. the patient will be much happier. Outcomes will be much better. Okay? Hope this helps. Let me know if you have any questions. I'll be glad to respond to you.